Thank you everyone for joining us. Today we are doing our first session in our new series, Taking the Pain Out of Pain Management. And today we will be discussing types of pain. And before we get started with that, I'd like to go ahead and do a land acknowledgement. We would like to acknowledge that the land in which we are gathered on today is the traditional territory of the Anishinaabe Nation, specifically the Chippewa Tri-Council comprised of the Chippewas of Beausoleil, Rama, and Georgina Island First Nations, and more recently, the Mississaugas of the Credit River First Nations. Ontario is covered by 46 treaties and other agreements and is home to many Indigenous nations from across Turtle Island, including the Inuit and Métis. These treaties and other agreements, including the One Dish with One Spoon Wampum Belt Covenant, are agreements to peaceably share and care for the land and its resources. Other Indigenous nations, Europeans, and newcomers were invited to this covenant in the spirit of respect, peace, and friendship. Most of us have come here as settlers, immigrants, or newcomers in this generation or generations past. We are all treaty people. Every day, we are mindful of broken covenants and strive to make this right. We commit to collaborating based on the foundational assumption that Indigenous people have the power, strength, and competency to develop culturally specific strategies for their communities. We are dedicated to honoring Indigenous self-determination, history, and culture, and are committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit people. And as most of you are aware, or you all are aware, today we are here as part of the Palliative Care ECHO Project. The Palliative Care ECHO Project is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illnesses. And of course, we would like to thank Health Canada for their financial contribution to the ECHO Project. We could not be here today without their assistance. Thank you, Health Canada. And for those of you who haven't been here before, my name is Amanda Tavalda, a communications, fundraising, and public relations specialist with Hospice Aurelia, and I will be acting as the host and moderator today. And our presenters are Kathy and Linda. Kathy and Linda, the floor is all yours.
Thank you, Amanda.
I'm Kathy McEwen. I am an RN and a nurse consultant with the North Simcoe Muskoka Hospice Palliative Care Network. And you can go ahead, Linda.
Thank you, Kathy. I'm Linda Meeks. I'm one of the education facilitators at the North Simcoe Muskoka Hospice Palliative Care Network. And my role is a little different from Kathy's, but we partner on several projects. And thank you, Kathy, for being my partner on this one.
You're welcome.
Before we get started, I would just like to remind everyone there is a QR code here. If you take a snapshot of it, you can complete a satisfaction survey following today's session. You can either do that through this QR code, or when you get a link to the recording, there will also be a link to survey completion as well. We would totally appreciate that if you could do that for us, because obviously that helps us improve in our work. And the other thing I just wanted to mention before we get started on today's topic is that Kathy and I are doing the first session of the series of Taking the Pain Out of Pain Management. We will be covering today the types of pain, and the following sessions will cover in order after ours the assessment of pain, pharmacological management, non-pharmacological management, and then the concept of total pain. You can go to our website and register for these. The information and the dates of all the courses will be housed on the website. So we're looking forward to those. So today's learning objectives, by the end of the session, participants will be able to understand the definition of pain and its prevalence in palliative care, understand the causes of pain and barriers to effective pain control, and understand the pathophysiology of pain, and in addition, describe the classification and types of pain. Uncontrolled pain is consistently listed as a primary source of fear for end-of-life care, as I'm sure that most of you are aware of. Palliative care aims to provide relief of pain and other physical symptoms, in addition to supportive care for patients and their families at end of life. Pain is often considered one of the most treatable symptoms in palliative care, and a request for pain management is a common reason for referral to palliative care physician specialists and palliative care teams. Identification of those patients at risk for increased pain near the end of life is important for a prompt initiation of a palliative approach and a specialist palliative care referral. So there are a few definitions of pain that are quite common. We like to use the one from McCaffrey and Pissarro from 1979 that states the definition of pain is whatever and whenever the person says it is. And the International Association for the Study of Pain defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain can be acute or persistent. It can be chronic, and both can occur at the same time. Pain is a general term that describes uncomfortable sensations in the body. It stems from the actuation of the nervous system, varying degrees by biological, psychosocial, and social factors. Individuals learn the concept of pain through their life experiences. A person reports an experience of pain, and it should be respected. Verbal description is only one of several behaviors to describe pain. Next, we'd like to talk about the prevalence of pain. Pain is a common and often devastating complication of progressive incurable diseases such as advanced cancer, AIDS, end-stage heart failure, and lung and motor neuron diseases. Up to 85% of patients with advanced cancer will experience pain. 2/3 of those patients rate their pain as moderate to severe. Up to 60% of patients with AIDS will experience neuropathic pain, and frequently this pain results as functional impairment. High levels of pain have also been found in patients with end-stage neurological disease, particularly neuropathic pain, and in end-stage lung and heart diseases. Needless suffering and poor quality of life are the outcomes of the failure to manage pain symptoms, as I'm sure most of you are also aware. The data shows that up to 85% of pain syndromes can be relatively well controlled with adherence to basic principles and guidelines of pain management. So as Kathy and I go through the types of pain today, in the next sessions, you will learn these basic principles and guidelines of pain management. Pain can be acute or chronic, or both at the same time. It can be unrelieved or poorly managed pain. And this is a burden on the person, the healthcare system, and society. And I was actually quite astounded when I found this information from the RNAO about what chronic pain costs the Canadian healthcare system. It's an astounding figure of between $47 billion to $60 billion a year. And that's more than the money spent on HIV, cancer, and heart disease combined. So next, I'd like to talk about causes and barriers of pain. Pain can be caused by tissue damage. The injury can also occur by injury to bone, soft tissue, and organs. It can come from the disease itself, such as cancer, or it can come from a physical injury, just like a cut or a broken bone. Pain can also be caused by nerve damage. Diseases such as diabetes can cause this nerve damage. Chemotherapy, HIV infection, and stroke can also cause nerve damage. Pain can also be caused by damage to the central nervous system or peripheral nerves. Barriers to effective pain control include problems associated with health professionals, problems associated with patients and their families, and also problems in the healthcare system itself. So problems related to the healthcare professional include inadequate knowledge of pain management, poor assessment of pain, concern about regulation of controlled substances, fear of patient addiction, concern about side effects of analgesics, and concern about patients becoming tolerant to analgesics. The problems related to the patient and their family include the reluctance to report pain because they have concern about distracting the physicians from their treatment of underlying disease. They may have fear that pain means that the disease is worse, or they have concern about not being a good patient. Then they are reluctant to actually report their pain symptoms. There's also a reluctance to actually take the pain medication because there's fear of addiction or the thought of becoming an addict. There are worries about unmanageable side effects, and there's concern about becoming tolerant to the pain medications. The problems related to the healthcare system include low priority given to pain treatment, restrictive regulations of the controlled substances, and problems of availability of treatment or access to it. This is a basic slide that shows you that pain can be acute or chronic. It can be classified as malignant, non-malignant, and also nociceptive, which includes somatic pain and visceral pain, and non-nociceptive, which it includes the CNS or peripheral nervous systems. We're going to go over those today. I will do part of it, and Kathy will do the other piece. In the classifications of pain, there are several scales that one can use. There's probably 10 or 11, and some of us have our favorite scales. Most of us working in hospices, cancer centers, and with cancer or palliative patients are well familiar with this 1 out of 10 scale, or the ESAS scale, which is the Edmonton Symptom Assessment Scale, revised version. Obviously, pain can be classified if we're talking about 0 to 10. Mild pain is the numerical number of 1 to 3. Moderate pain is 4 to 6 out of 10, and severe would be 7 to 10 out of 10. So information on this can be found and how to use the ESAS also on our website, as well as we did previous sessions on the algorithm of pain management from Cancer Care Ontario. You'll be able to find that also on our website. And this is a fantastic tool that actually goes through how to assess pain and how to intervene with the treatments of pain based on the classification of pain using the ESAS scales and the numerical scale of 0 to 10. So that's a great resource for you. The classification of pain, acute pain. Acute pain develops over a short period of time and tends to occur suddenly, often as a result of a known injury, illness, or medical procedure. It typically lasts less than 6 months and obviously acts as a warning to your body about a disease or a threat. So if one is unsure about the disease or threat, most often that is when it's investigated, and usually a more serious disease is found if it hasn't resulted from a very minor injury like a cut or a burn. And typically the injury resolves after the injury is healed, but it can obviously, if not healed, develop into chronic pain. And examples of this include postoperative pain, labor pain, trauma such as lacerations, fractures, sprains, infections, and angina. When we talk about chronic pain, this is the pain that lasts or comes and goes over multiple months or years, and typically it would be classified as chronic pain if it's lasting longer than 6 months. And it can result from a variety of conditions or something that is of unknown cause. And examples of this include arthritis, neck pain, back pain, headaches, and fibromyalgia. Of course, there can be many more causes of chronic pain. And when we speak of malignant versus non-malignant pain, that's obviously very simple because malignant pain arises from a cancerous cause and non-malignant pain arises from non-cancerous causes. Nociceptive pain is defined as the processing of noxious stimuli by an intact nervous system, usually responsive to analgesics, NSAIDs, or physical modalities. Nociceptive pain is damage to underlying soft and bone tissues by disease or trauma, and it can result from injuries such as cuts, burns, bruises, or fractures, and also bone metastases. It may also result from certain health conditions that cause tissue inflammation and damage such as arthritis, osteoporosis, or inflammatory bowel disease. Now, when we talk about nociceptive pain, then obviously we break it down into somatic pain and visceral pain. Somatic pain arises from bone, joint, muscle, skin, or connective tissue, and it's usually described as an aching or a throbbing in its quality, and it's usually very well localized. Visceral pain arises from organs such as your GI tract or bladder. It can be tumor involvement of the organ capsule that causes aching and fairly well localized pain, or it could be from obstruction of a hollow organ that causes intermittent cramping and poorly localized pain. It's important to realize the difference of those in your assessment because obviously the treatment may be different. Neuropathic pain is the abnormal processing of sensory as a result of injury of the peripheral or the central nervous system. And it's a damage or improper functioning or misfiring of our neurons. And it can be described as shooting in nature and usually constant or a burning sensation. And examples of this would include carpal tunnel syndrome, post-herpetic neuralgia, trigeminal neuralgia, diabetic neuropathies, HIV, MS, and from the central nervous system, stroke or phantom limb pain. And now I'd like to hand this over to Kathy to continue.
Thanks, Linda. So nosoplastic pain is the next classification of pain. Nosoplastic pain or central sensitization is a type of pain which is mechanically different from the normal nociceptive pain caused by inflammation and tissue damage, or from neuropathic pain which results from nerve damage. It can occur in combination with other types of pain or in isolation. Its location may be generalized or suggested multifocal, and it can be more intense than would be expected from any associated physical cause. It's thought to be a dysfunction of the central nervous system where the processing of pain has become distorted or oversensitized. Central sensitization is a term referring to the hyperexcitability of the nervous system, which usually includes hyperalgesia, which is the increased sensitivity to pain, and allodynia, which is a painful perception of a non-painful stimuli. Fibromyalgia is a classic example of nociplastic pain. So the World Health Organization not recently, but has updated the International Classification for Diseases. For the first time, they have included chronic pain and provided specific pain diagnoses. Under this new system, chronic pain is classified as either chronic primary pain or chronic secondary pain. Chronic primary pain is defined as a pain that persists for longer than 3 months and is associated with a significant emotional distress or functional disability that cannot be explained by another chronic condition. This new definition applies to chronic pain syndromes that are best conceived as health conditions in their own right. Examples of chronic primary pain conditions include fibromyalgia, complex regional pain syndromes, migraines, irritable bowel syndrome, and other nonspecific low back pains. Chronic secondary pain syndromes are defined as pain that may initially be regarded as a symptom of other diseases, having the said disease being the underlying cause. However, a diagnosis of chronic secondary pain marks the stage when the chronic pain becomes a problem in its own right. In many cases, the chronic pain may continue beyond successful treatment of the initial cause. In such cases, the pain diagnosis will remain even after the diagnosis of the underlying disease is no longer relevant. Examples of chronic secondary pain would be chronic pain related to some cancers, surgeries, an injury from a trauma, internal diseases, and diseases of the muscles, bones, or joints. This is a clinical decision tree for clinicians that was developed by the International Association for the Study of Pain. And they developed some clinical criteria for nosoplastic pain, essentially for the musculoskeletal system at this time. And it implies that in order to clinically classify nosoplastic pain, patients must report pain of at least 3 months duration, report a regional rather than a discrete pain distribution. They must also report that this pain cannot entirely be explained by nociceptive or neuropathic pain mechanisms. They must also show signs of pain hypersensitivity. This hypersensitivity phenomena, such as a static or dynamic mechanical allodynia, which is, testing with light touch. And if this person has an exaggerated response, it would be considered, a static or dynamic mechanical allodynia, along with pressure. Pressure and light touch would create this type of allodynia. Or heat or cold allodynia, which is, an exaggerated response to heat or cold. If these 4 requirements are met, the patient can be classified as having possible nosoplastic pain. In cases where all 4 requirements are fulfilled, such as sensitivity to touch, movement, pressure, heat, or cold, plus the patient has a history of pain hypersensitivity in the region of pain and has at least one of the defined comorbidities, such as an increased sensitivity to sound, light, odors, or sleep disturbances, fatigue, and often frequently they're awoken in the night, and some may have cognitive problems. This pain is classified as a probable nosoplastic pain. The presence of nociceptive or neuropathic pain does not exclude the possibility of the concurrence of nosoplastic pain, but if nociceptive or neuropathic pain is present, they cannot be entirely responsible for this type of pain, for nosoplastic pain. So this is for pain pathways. This picture is depicting transduction, transmission, perception, and modulation. We're going to talk about transduction, transmission, perception, and modulation. Nociceptive cells, they're found throughout the body, the whole body. Any noxious stimulus that can cause cell damage from either thermals, being extreme heat or cold, or from mechanicals such as a trauma, or chemicals from an infection or ischemia. These damages to nociceptive cells will release excitatory neurotransmitters that can activate A delta fibers and C delta fibers, and an action potential will then occur, otherwise known as transduction. This action potential occurs, and this impulse is then transmitted along a first-order neuron. This first-order neuron enters in through the dorsal horn of the posterior dorsal horn of the spinal cord, where it would synapse with a second-ordered neuron. This impulse will travel along this second-ordered neuron to the opposite side of the dorsal horn and continues up the spinal cord, just to sort of an understanding that if you had an injury to your left hand, say you burnt your left hand, that pain impulse would synapse in the posterior dorsal horn of the spinal cord, but then it would travel to the opposite side and it would travel up the spinal cord on the right-hand side. Just that it always goes to the opposite side. Same as if the injury were in the right hand, it would travel up the left side of the spinal cord. It travels then on through the brainstem to the thalamus. This second-order neuron within the thalamus will synapse with the third-order neuron, and this impulse will continue along this neuron to the appropriate area of the cerebral cortex. Perception is the conscious experience of pain perceived by the individual. So the descending pathway has a second-ordered neuron also, which is called the serotonergic or noradrenergic neuron, which travels down to the dorsal horn of the spinal cord. It works to control the first-order and second-ordered neuron of the ascending pathway in the dorsal horn in an area called the substantia gelatinosa, which helps to control pain signals to the brain through the release of norepinephrine and serotonin and endogenous opioids called endorphins and enkephalins. The release of these chemicals inhibit or block the release of substance P, a neurotransmitter involved in the transmission of the pain signal originally to the brain. This serotonergic noradrenergic neuron stimulates smaller neurons, also known as interneurons, in the substantia gelatinosa to release endogenous opioids known as enkephalins, which will also block pain signals in the brain, which is modulation. So we're going to do just some short case studies here. And you can just put your answers into the chat box. They should just be pretty easy to answer if you've been paying attention. Anyway, Mary, she is a 50-year-old woman with a previous history of breast cancer. She has been declared cancer-free for the past 6 years. Mary develops right upper quadrant abdominal pain that wraps around her ribs into her back and is described as constant, deep, and a dull ache associated with nausea. What type of pain do you believe Mary might be experiencing? And just put it in the chat box. Yes.
We have malignant.
Mm-hmm.
Okay. Somatic, chronic pain, visceral, a little bit of everything.
So malignant is correct, and it would be nociceptive, yes, visceral pain. Gina, she is a 48-year-old woman who suffers with mental illness. She's very overweight. She comes into the emergency department frequently by ambulance, usually in the middle of the night, complaining of pain and always wearing sunglasses. Gina has no family physician and has pain that is not well described, only that I'm sore all over. It's mainly in her joints, not just one joint, but all of her joints. Gina lives alone. She has no one to advocate for her. Her previous visits to the ER, she has been aggressive verbally and physically with the staff. Gina has been labeled a frequent flyer who is drug seeking. Unfortunately, Gina's medical treatment in the emergency room is not optimum and is usually discharged with little investigation or treatment. Gina told the nurse that during her assessment that no one understands the pain I am in. I've had it for over a year. Gina cursed at the nurse when she attempted to place a blood pressure cuff, which caused an exaggerated pain response, and will not allow the nurse to cover her with a sheet, screaming in pain with the attempt. She says, I don't know why I come here. You people never listen. You never do anything. All you people ever do is tell me to use heat or cold or ice. Don't you know that causes me pain? Gina admits to feeling tired all the time. She wakes frequently in the night. When the nurse inquires about the sunglasses and if she's having a headache, she tells the nurse that the bright lights bother her eyes. So what type of pain do we think Gina might be experiencing? Absolutely. Thank you. Yeah. Excellent. That's great. And it's also a chronic pain, right? And it's not this would not necessarily be considered this would be a non-malignant pain. It would also be chronic. Bill is a 78-year-old gentleman. He was diagnosed with prostate cancer. Bill has done well for the past 10 years, but has developed pain in his right upper arm and his left upper leg. The pain is described as a constant ache. Sometimes it just throbs. It gets much worse when I stand or attempt to walk. I'm even awoken from sleep if I turn over the wrong way. What type of pain do we think Bill might be experiencing? Anyone else? Somatic is absolutely correct. Would you consider this to be acute? It could be acute or chronic, yeah. And it could be malignant, absolutely. Yeah. Usually starts out acute, but it can end up being chronic pain, bone pain. Okay, Wanda, she's a 54-year-old woman with a diagnosis of uterine cancer. She's been receiving chemotherapy treatments. Recently, Wanda has developed some side effects from the chemotherapy. Wanda describes that she's having cramps in her feet and they feel like they're on fire. She states, I cannot sleep and it's really hard to walk. My pain medication's not helping at all. What type of pain do we think Wanda is experiencing? Absolutely. Yeah. Would we consider this to be chronic or acute type pain? Neuropathic pain? Absolutely. I would say that it was both. Thank you, Maria. Would you consider this to be malignant or non-malignant type pain? Absolutely. Thank you. We have some true or false questions. Nociceptive pain is somatic pain that arises from the bone, joints and muscles, skin or connective tissue, usually aching and throbbing in quality, and it's very well localized. Visceral pain that arises from the organs or the tissues in the chest or the abdomen, usually described as deep aching or squeezing in quality, and it's not well localized. Would this be true or false for nociceptive pain? Yeah. Yeah, absolutely. Neuropathic pain can arise from the peripheral nerves, the spinal cord, and the brain, and is often described as a burning, shooting, pins and needles, or an electrical shock. Could this be true or false? Yep. Everybody's answering quickly. It's great.
They were quick on that one.
They sure were. Anyway, the last question here. So nosoplastic pain was introduced by the International Association for the Study of Pain in 2017 as a third mechanistic pain descriptor, in addition to nociceptive and neuropathic pain. Nosoplastic pain is defined as pain that arises from an altered nociception despite no clear evidence of an actual or threatened tissue damage, causing the activation of peripheral nociceptors, absolutely true, or evidence of disease or a lesion of the somatosensory system causing the pain. Yes, this is true. Okay. Guys, were excellent. We really hope that you've enjoyed today's, I think Amanda will address this one in the chat. We hope you enjoyed your session today. Please remember to complete our satisfaction survey. And are there any questions surrounding anything that was discussed here today?
And I've put the survey link in the chat. And just to answer, Angie asked when the recording will be sent out. It'll be sent out in about 3 business days. Usually it takes us to get it downloaded and formatted properly and sent out in an email. As well, if there's any other resources we feel would be appropriate, we'll also send a link to those as well. Be sure to check your junk mail in case you don't see it. Sometimes it will be filtered into that folder. And thank you so much, Linda and Kathy. That was fantastic. I think it was, there is a question. What treatment is recommended for the last type of pain?
This particular session wasn't about treatments or, medications, but I will tell you that nosoplastic pain is considered to be treated. It's a non-pharmacological treatment for nosoplastic pain. This is the problem. The problem with a lot of people who have this type of pain, they've been treated with a lot of opioids and other medications that they are somewhat, I don't like to say addicted to, but they're not working for them anymore. And non-pharmacological treatments are the best treatment for nosoplastic pains. They kind of tell people that, increasing their mobility, probably getting in with physiotherapy. They can do things like a lot of counseling. I would imagine that these types of people would do best by attending like a pain clinic. Yeah, you could. I would see OT and PT and pain doctor specialists or nurse practitioners who are specialists with pain being involved in their care, absolutely. But non-pharmacological approach is the best approach for this type of pain. They even, suggest things like TENS machines or acupuncture or massage. All of those things to attempt to modulate that kind of pain would be most appropriate. So, but I'm hopeful that in the next, I'm not sure where that is, but the non-pharmacological part of our series, we should be able to address that. a lot deeper. Okay. I hope that answered that person's questions.
And just to answer the question about when the next session is, I've just posted the link there that will have the ability to register through, but the assessment of pain is on June 29th. Be sure to register and get your spot secured for that. And we will also send out a reminder as well. Once you've registered, we'll send a reminder that the session is coming up. Thank you so much, everyone.
Thank you.
Thank you.
Have a great day.